the approved targets for Parkinson's surgery are basically three: the VIM in the thalamus that can be treated with lesions or DBS, but also the subthalamus and the globus pallidus pars interna that we call STN or GPI respectively. And STN and GPI are the main targets these days for deep brain stimulation. They're officially approved, and because we've been using them for a few years now, or actually more than a few years, it's been 3 decades at this point, we have a better understanding of what they can do. So especially in the early eras of deep brain stimulation, most people will have said that STN DBS is the only procedure for Parkinson's disease. Then there's been a renewed interest in the States for a variety of reasons towards GPI DBS, and so this led to the debate whether STN or GPI was the better target for Parkinson's patients. So this inspired a number of well-done studies randomizing patients to either target, and now we have a better understanding based on evidence of what these two targets, when stimulated, can achieve. And in short, it's not that one is better than the other. We know what's the best candidate for each target. So the job of the neurologist and neurosurgeon is to identify the right candidate for each target. STN is particularly useful when we want to achieve a great effect on bradykinesia, thereby reducing the amount of medications, levodopa taken by the patients. So anytime our goal is to keep the doses of medications low, we prefer STN. An example of this would be people having psychiatric complications coming from drugs, or people of a younger age where we can lower the medication, use stimulation for many years, and then 10, 15 years later, we can increase again the medication. So it gives us the opportunity to use a scalable approach in the years to come. At the same time, STN DBS can also induce dyskinesias, it can induce depression or mania because it's a small target, so we can obtain more side effects, so it's less forgiving as a target. The reason why we try to do it mainly in super healthy younger individual. GPI instead is more forgiving, is a bigger target. We can target just the motor section of the nucleus, and we achieve mainly motor results from it. It's certainly the greatest option for dyskinesias, but because it's not so effective for bradykinesia, people don't reduce the medication typically too much. So it's an ideal target for people who are a little bit more frail on all the older age of the spectrum, so where we want to achieve some improvement of quality of life without risking a worsening of cognition, balance, freezing of gait. Like I said, we now know that they're effective. Actually, the studies comparing them concluded that they're equal, but in reality, we know that for each candidate, we have a better solution, either STN or GPI. And I should say that in some cases in the past, we started with one target and then we had to add the other targets. For example, GPI initially, then bradykinesia worsens, we could not increase medication too much, then you will add STN DBS. But we also had STN DBS treated patients who developed dyskinesias because of the stimulation, and then we had to do GPI DBS on top to take care of the dyskinesias. Not common, but in theory, it's not either or. In some people, it's also both.